Hi, I'm Virginie, and today we're going to discuss complications after tours. For the purposes of this talk, we're going to focus primarily on tours directly associated complications. However, it's important to note that in this patient population, there are also systemic complications that may occur, and you should take this into consideration when you're counseling patients about surgery. We'll also sort of largely exclude discussing some of the complications that may be related to neck dissection, which is often done concomitantly with TORS, especially when treating oropharyngeal cancer. So there are some local injuries that can occur. These usually are due to tongue laceration can happen with the suture that's often placed through the tongue to help with retraction. There also can be inadvertent dental injury, both from placement of the mouth gag or from movement of robotic arms. This is where it's important to have a watchful bedside assist, especially when introducing new arms or changing instruments. I tend to use aquaplast for the upper dentition as well as duoderm for the lower dentition. And this helps really protect the teeth from the mouth gag during suspension. I think we skipped over this slide. Sorry, I'm just trying to get all my systems working. Some complications after tours, the main ones we're going to talk about are bleeding, dysphagia, as well as infection, or really, which is from a fistula or inadvertent perforation during the resection. So let's start with bleeding. Risk factors for bleeding include larger primary tumors, greater extent of resection, prior radiation, as well as perioperative anticoagulation. Following tours, bleeding is the cause of 30% of readmissions. The severity of post-tours hemorrhage can range from minor bleeding treated with observation to catastrophic hemorrhage, leading to an emergent airway procedure, as well as death. A large study was done which showed that self-reported complications after tours gave a catastrophic bleed rate of about 3.5% and a mortality rate after tours due to bleeding of 0.3%. So this is a retrospective study from WashU St. Louis looking at postoperative hemorrhage after tours. This study looked at a database information from New York, California, and Florida. And they found that the overall percentage of surgery-related complications within 30 days was 51%. This is out of 111 patients. And that postoperative hemorrhage was 26%. Pain was 13%. And then they did look at some systemic complications such as pneumonia and dehydration, and those were found to be around the low teens. This study is a systematic review from Dr. Holsinger and Bob Ferris's group looking at bleeding complications after tours. It was just published last year in the Laryngoscope. And what they found in this literature, the rate of bleeding after tours was 5.8%. The post-tours hemorrhage rate ranged from anywhere from 3.1 to 19%. And they also found that the median time to hemorrhage after tours was on postoperative day 8. Minor versus major bleeding was examined in 5 of these 13 studies, and they found that studies that assess bleeding severity, minor and major hemorrhage, occurred postoperatively in 106 and 58 patients. This is out of a pool of 5,700 cases. And so the minor hemorrhage rate was 5.2%, and the major hemorrhage rate was 2.9%. Further delving into the study, they specifically looked at transcervical arterial ligation. 4 studies were examined that had information about this, and 3 studies ligated the entire ECA. The 4th study did specify how the transcervical artery ligation took place. And what's interesting to note here is that when looking at all episodes of bleeding, there was no significant difference in bleeding risk between the ligation group and the non-ligation group. However, when they went back and looked at major incidents of bleeding versus minor, they were able to see that the folks who did not do transcervical arterial ligation had a increased rate of major bleeding, which was 3.6% versus the folks who do ligation, which was 1.4%. The risk ratio and confidence interval show that this isn't significant. However, I would say that over time, transcervical arterial ligation has become more and more so the standard of care. If we look at the ECOG 3311, one of the criteria for inclusion in the study was to perform transcervical arterial ligation at the time of neck dissection. And so it's something that I do in my practice. It's easy to forget because it's usually the end of the case and you're trying to just be done. But in our own practice, we've noticed a difference in decreasing the number of major bleeding or catastrophic bleeding. The next thing we're going to talk about is dysphagia. Now, I would argue dysphagia is not really a complication after TORS. You can expect dysphagia, especially with more extensive resections. However, the timeline on how we should counsel patients to determine how long they can expect to have dysphagia really plays a part in whether or not they had surgery alone or if they can expect to undergo adjuvant treatment. This is a paper we produced during my fellowship at OHSU, and we looked at long-term functional outcomes, including dysphagia in patients undergoing TORS as part of their treatment for oropharynx cancer. And there are a lot of graphs here, but the point is that in the TORS-only group, at 3 months post-op, their E10 scores were no longer significant from baseline. So they weren't quite returned to baseline, but there was no statistical significance. And this is important, and other studies agree. This is a prospective study from Pittsburgh outlining their experience with short-term dysphagia after robotic surgery for oropharynx cancer. And they reported pre-op patients had about a 14% rate of dysphagia. Now, patients that were included in the ECOG 3311 study, part of those metrics involved doing a baseline MBS, and so there may have been a little bit more information. But for the most part, patients reported about a 14% rate of dysphagia pre-op. And when we look at this graph, what it shows is that patients will have improved dysphagia on post-op day 30 compared to post-op day 1, and definitely compared to post-op day 7, where they're really having a lot of pain and dysphagia. And over time, they found that most people went back to baseline by 3 months. And this is important because if you're counseling a patient to undergo surgery and then their expectation that they're going to undergo adjuvant radiation as well, they need to understand that their swallowing will not be back to baseline by the time they start adjuvant treatment. And it's relevant, again, for proper patient counseling and expectation. And again, any adjuvant treatment will kind of compound their dysphagia, especially throughout the course of treatment. But in the TORS alone population, by 3 months, patients tend to normalize their swallowing outcomes. We're going to review 2 less common complications. Unfortunately, this is a short talk, so we're not able to delve too much into it. This was an interesting paper I saw looking at first bite syndrome in patients who had undergone transcervical arterial ligation. And basically, their thought was that when ligating branches off the ECA, maybe we cause denervation of postgangliotic sympathetic fibers to the parotid gland, and this can account for first bite syndrome. Luckily, most patients have resolution of symptoms. This is a cohort of 6 patients. The mean duration of symptoms they found was around 66 days. Most patients could be observed. Some people ended up needing Botox, but I found this to be an interesting potential complication, a little bit more related to the transcervical arterial ligation. And then the other one that was interesting was spondylodiscitis. This is in a French group who reported their experience, and they found that in 7 cases out of 1,084 over a span of 7 years, patients developed spondylodiscitis. Their risk factors included prior CRT, malnutrition or overweight, corticosteroid therapy, as well as comorbidities, including diabetes, kidney failure, HIV, drug addiction, and coronopathy. What is interesting, again, to note about these folks is that they, again, presented with the typical symptoms, and the this could be quite lethal. In fact, in their case series, 3 out of 7 patients died succumbing to their infection. And so it's important to note the average time to presentation was around 2 months. And so it's something to keep in mind when, again, seeing patients or counseling them, as this could be an unexpected complication, though rare. Thank you for listening. I hope you found something useful in this talk. If you do go back and look through the slides, I've included additional information, especially about each of those articles presented in some of the notes under the PowerPoint slides. Thank you. Bye-bye.